Good morning, good afternoon, good evening, wherever you are. Thank you so much for coming on to another intensive care at home live stream. Today, I want to talk about a blueprint for hospital discharge with tracheostomy, with intensive care at home. This is also hospital or ICU discharge. Sometimes tracheostomy patients go home from ICU directly. Sometimes they go home from respiratory wards, but I'll break all of that down a bit later. I want to welcome you for joining me on this call. I also want to welcome you if you're watching this on replay. I do these YouTube lives usually once a week, usually at 10:30 a.m. on a Sunday, Sydney, Melbourne time, which currently is 7:30 p.m. Eastern Standard Time on a Saturday night, which is 4:30 p.m. Pacific Time. But the times will vary slightly depending on whether North America is in daylight saving or we are in daylight saving here. But you get the right times through my email if you're on my email subscriber list. In any case, what makes me, before we go into today's topic, what makes me qualified to talk about a blueprint for hospital and ICU discharges with tracheostomy with intensive care at home? I'm a critical care nurse by background. I have worked in critical care / intensive care for nearly 25 years in 3 different countries, where I have worked as a nurse manager for over 5 years. I have worked with intensive care at home early on in my nursing career in the late 1990s and early 2000s in Germany. And I'm also the founder and managing director of intensive care at home here in Melbourne, Australia, since 2012. And we've been successfully operating intensive care at home in the community since 2012 in Sydney, Melbourne, Brisbane, but also in regional and rural areas, Victoria, New South Wales, Queensland. And we've been hugely successful there. We are employing hundreds of years of intensive care nursing experience in the community, which is unheard of, unmatched by any other provider. We are the only service provider in English-speaking countries, as far as I'm aware, who has achieved third-party accreditation for intensive care at home nursing. We have built unique intellectual property in this space, making seamless transitions from intensive care to an intensive care at home environment. I'm also a consultant and advocate for families in intensive care, and you can get more information at intensivecarehotline.com, where we helped thousands of families over the years of critically ill patients in intensive care all over the world. You can get more information at intensivecarehotline.com. Now, before we go into today's topic, also want to acknowledge our viewers here. Feel free to type your questions into the chat pad. I can also bring you on later after I've gone through what I want to talk about today. I can bring you on the show later so you can talk to me directly. In the meantime, type your questions into the chat pad. Ideally, keep them to today's topic. Once we've gone through today's topic, feel free to ask any other questions. Leo, I can see you're here. Thank you for your, hi Patrick, just fine to wish you a happy and holy Easter. Thank you for your compassion and guidance. Nice to see you again, Leo. I hope things are going well and are improving on your end. As you're probably aware, I did speak to your brother this week. So hopefully your dad will be back home very soon. Okay, without further ado, let's go into today's topic. So a blueprint for hospital and ICU discharges for patients with tracheostomy. I should say adults and children. We've done both and we are doing both. So why is it important to talk about tracheostomy discharges? You've heard me speaking extensively about tracheostomy and ventilation discharges from ICU home. Why do I today want to talk about tracheostomy specifically. I tell you why I want to talk about tracheostomy discharges specifically without ICU, without ventilation, simply because, you know, there are a lot of patients in hospital, either in ICU or on hospital wards, hospital floors, that are sitting there with a tracheostomy, and hospitals really don't know what to do, or they want to send them home with insufficient support, right? And that's dangerous, and it has cost lives. Or they want to send them home, quote unquote, training family members. Well, let me be very clear here. Looking after a tracheostomy is an intensive care nursing skill, right? It's nothing else but an intensive care nursing skill, right? And the reason for that is, you know, once you've worked in ICU for a while, it's inevitable to look after patients with a tracheostomy, and you get, you know, in ICU, you get all the specialist training, and it takes years to master intensive care, right? It takes years of practice. You know, when it comes to patients with a tracheostomy, right? So by then sending patients to a hospital ward, for example, a hospital floor, which is often the next step, you will see that those patients are being moved close to the nurse's desk, because no one can look after them, and they need to be close to the nursing staff because they don't have the ICU nursing skills on the floor or on the ward, right? Which is why, you know, the best and the safest option really is going home. Now, often you will also find that if a patient with a tracheostomy needs rehabilitation, whether it's neurological rehabilitation, cardiac rehabilitation, whatever the case may be, you will find it's very difficult for them to go to a rehabilitation facility because they don't have the skills to look after a tracheostomy, you know. So that's why this is such a unique skill. And we have seen that patients in the community or on the hospital ward have passed away because they don't have the skills around them to look after a tracheostomy. That's how dangerous it is. You know, it's fairly risky going from ICU to a hospital floor or hospital ward. For our US audience, it's very risky going from ICU to an LTAC, a long-term acute care facility, or even subacute. It's very risky. Patients die. They don't get the care and treatment they need, you know, and they're often left to their own devices with very negative consequences. So that's why intensive care at home is the best option here. Okay, so that's hopefully sort of setting the scene why I want to make a video, or why I'm making a video about this, because if you don't have intensive care nurses 24 hours a day with a tracheostomy, if you can't go home with a tracheostomy, assuming you can't be decannulated, I mean, the goal for anyone on a ventilator with a tracheostomy should be to be decannulated, to have the tracheostomy removed. That should always be the goal. Let me be very clear here, that always needs to be the goal. But this video really is for families of patients where a tracheostomy decannulation is not on the cards, not in the short term, not in the long run. That's who this video really is for today, so that you know what your next steps are, right? Before I break it down further, let's also look at the evidence. You know, healthcare is all about evidence-based. So, for example, when patients go home with a tracheostomy, they need to have 24-hour specialist nursing care, not general nursing care. And the reason they need specialist nursing care with intensive care nurses 24 hours a day is, once again, because intensive care nurses are the only nurses that are properly trained on taking care of a tracheostomy. There are some emergency department nurses as well, because they would have done studies for postgraduate critical care. They would know what to do as well. But the bottom line is, it must be a critical care nurse 24 hours a day. Reason being is that there's overwhelming evidence for that. So the research has been done. So when you look at our website, intensivecarehome.com, you'll find a section, the mechanical home ventilation guidelines. Now, these evidence-based mechanical home ventilation guidelines have been published 15, 20 years ago in Germany, where intensive care at home, Germany was the first country that embraced intensive care at home on a large scale, right? And they've come up with the guidelines, which are now the mechanical home ventilation guidelines that are evidence-based, because intensive care at home has been around in Germany for nearly 30 years now. And patients are going home from ICU directly with critical care nurses 24 hours a day. The same in Australia now with intensive care at home. We are doing the same there. Our clients go home from ICU directly 24 hours a day with critical care nurses. It cuts the cost of an ICU bed by 50%. That's 50, right? And it is an absolute no-brainer, right? It's a win-win situation. It improves the quality of life for patients and their families, or quality of end of life. It cuts the cost of an ICU bed by 50%, and it frees up the most sought after bed in a hospital, which is the ICU bed. It's a win-win situation altogether. And thank God now there are guidelines around it. And thank God now there's providers like ours who are third-party accredited for intensive care at home nursing that can make it happen. Now, let me also be clear and mention a word of warning here, right? So in our earlier days, when we first got started with intensive care at home, there were some clients at home where the funding body only funded night shifts for us, for clients with a tracheostomy, right? And we were making some noise and saying, look, funding body, and I'm not going to say who those funding bodies are now, you need to fund 24-hour nursing care. Here is the evidence for it, you know, and if you're not funding it, those patients are at risk of dying, right? And we were laughed at. We were told, oh, you just want to promote your business and you don't know what you're talking about, you know. And we realized at the time we are not talking to intensive care professionals. We're talking to people who want to cut cost. Anyway, cutting a long story short, 3 out of those clients died during times when we were not there, just as we predicted. And, you know, we are still appalled to this day that this is what's happened. And, you know, we did go back to the funding bodies, which in this instance was the NDIS here in Australia, and we're still waiting for a response. I do believe the families that lost their loved ones are so traumatized they still can't face what's happened at the time. And that's why we're all about quality and safety. Show me any other organization in the community when it comes to long-term ventilation, tracheostomy, or tracheostomy care that's bringing in standards and quality care. Show me one organization that's doing what we are doing in terms of advocacy, that's doing what we are doing in terms of educating people. If people have something to say about a tracheostomy and a ventilator in the community, why are they not saying it, right? Right? Why are they not saying it? Why are they not bringing in quality standards, which is what we are doing here? Okay, so now that we've set the scene around what is actually needed in the community, which is 24-hour nursing care with critical care nurses for patients with a tracheostomy, adults and children, right? It is important that the funding is getting organized. So how does that work? So here in Australia, you know, for example, with intensive care at home, we are accredited to get NDIS funding to work with NDIS participants. We are accredited to work with TAC clients in Victoria. We are accredited to work with iCare clients in New South Wales, as well as we are NIISQ accredited in Queensland, and we are DVA approved all around Australia. We also have received funding through public hospitals, private health funds, departments of health. So really, there's a number of funding bodies that are accessible to you if you're watching this. Now, I know we have a lot of viewers from the US and from the UK as well. The principle is the same. You will need critical care nurses 24 hours a day. Anything less is dangerous, and it could cost your loved one's life. And like I said, we have all the evidence here. But the principle is the same. You've got not only an argument for taking your loved one home from ICU, from a hospital, from LTAC, for quality of life purposes, quality of end of life purposes, right? You have the reasons, you know, that you're helping the hospital to free up the bed that they so desperately need. You have an argument to free up hospital resources, including staff equipment that they so desperately need. And you have an argument to cut the cost of the intensive care bed or hospital bed by approximately half, by approximately 50%. So really all your arguments are on your side. And if you are in the US or in the UK and you want help from us, please reach out to us. We can help you privately. So, okay, coming back to, you know, what we're doing here in Australia. The next thing that you need to do is approach the appropriate funding body. Like I said, NDIS would be the most common one at the moment. But also, you know, God forbid, if you were or your loved one were in a car accident, you know, is that TAC in Victoria, is that ICANN New South Wales, or any other motor vehicle accident insurance, you know, or are you a DVA client, for example? Are you could you get funding through the Department of Health? Do you have private health insurance? Would the hospital pay for it? Because they want the bed, so they might as well pay for it, you know. So there's numerous ways to go about funding. If you are going through a funding scheme like NDIS, TAC, NIISQ, ICARE, DVA, you need a case manager, or for the NDIS, it's an NDIS support coordinator in particular. We provide NDIS support coordination, right? And we have our own in-house level 2 and level 3 NDIS support coordinator, Amanda. And level 3 NDIS support coordination in particular is specialist support coordination, which is really what is needed for clients with tracheostomy, right? Because it's such a uniquely specialized area in healthcare that you can't just leave that to anyone, right? Once you've got the NDIS, the right NDIS support coordinator, and I highly encourage you to reach out to us if you need an NDIS support coordinator, then it's all about getting on the NDIS, getting an NDIS plan, getting engaged with a complex planner from the NDIS, right? It's a case of then getting doctor's letters for 24-hour nursing care, nursing assessment for 24-hour nursing care. We can also do nursing assessments with intensive care at home. Not many nursing services can do nursing assessments for tracheostomy or ventilated patients because most nursing services are general nursing services. They don't deal with tracheostomy or ventilation. So even, you know, if you reach out to any other general service provider, you know, they might tell you that they can look after a tracheostomy, but can they really? You know, what are their credentials? You got to ask all the right questions, you know. Then once you've selected an NDI support coordinator, like I said, nursing assessment, OT, functional capacity assessment you need a physiotherapy report, you probably need a doctor's letter, and that is pretty much what you need to get NDIS funding over the line. And it's fairly similar with other funding bodies. You know, you just need to provide the evidence, which is really important. So once that's out of the way, then, you know, funding will be approved. Then you can start looking with us to build a team. You know, you want the right team in your home, right? You don't just want anyone working with you or your loved one. You want the right team, you know, and we get you engaged and included in building the team. You know, we don't just send you anyone, we send you nurses that you feel comfortable with, you know, that are the right fit for your loved one or for you and for your family, of course. Next, once the right team has been built, you know, it's a case of managing the day-to-day nursing care that needs to be managed with a tracheostomy. You know, I assume if you're watching this and, you know, you might have a loved one with a tracheostomy, you know, often they are immobile, so you need to look at all the equipment, hospital bed, hoist, lifting machines, spare tracheostomies, suction machines, you know, monitors, potentially wheelchair, you know, so that everything is at home, nebulizers, you know, those are the most things that you need when you have a tracheostomy at home. You know, could be more, sometimes could be less, you know, also things like, you know, blood pressure cuff, stethoscope, so we can, the nurses can listen to your chest, making sure there's air going in and so forth. But also on a day-by-day basis, as you probably have observed in the hospital, it's also a case of in the hospital, you're often confined to a hospital bed, whereas at home it's all about providing the community access as well. One of the depressing things about hospitals is, patients are stuck in a hospital bed, in an ICU bed for weeks or for months on end. And that is really the main advantage of our service, that all of a sudden you can go home and you can participate in a life that you want. We enable community access. That's really a big thing for us. All of our clients, without any exception, have community access, irregardless of their perceived limitations, irregardless of whether they're on a ventilator, whether they have a tracheostomy, whether they have both, whether they have spinal injuries, whether they can't move, they still have community access. We take them out, and that is one of the main differences between hospital and home. In a hospital, you might be lucky if someone takes you down the courtyard, or if someone sits you at the window for some daylight, So then once you're at home, everything is set up, you will see, similar to a hospital, what the nurses are doing, like giving regular nebulizers, regular suctioning, making sure that tracheostomy is patent, making sure the inner tube is changed on a regular basis if there is an inner tube. Most patients have an inner tube, but there are some patients who don't have an inner tube, especially pediatrics. They don't have an inner tube often, but adults often have an inner tube. And it's important that the tracheostomy patency is established at all times. A tracheostomy block can literally be fatal, which is why your loved one, or if you are the patient, need intensive care nurses 24 hours a day, nothing less than that. Also when it comes to dressing changes, it's an intensive care nursing skill. It's an intensive care nursing skill to look at skin integrity, and if the skin is broken, for example, making sure you apply the right dressings, for example. Also, if, for example, your loved one, or you have a cuffed tracheostomy as opposed to an uncuffed tracheostomy, making sure the cuff is up, is inflated the right way, making sure the cuff goes up or down for the right circumstances. Sometimes the cuff can go down, maybe for swallowing exercises, for breathing exercises, but you still need the intensive care nurse to know how to take the cuff up and down, and knowing how much to inflate, and those are very unique and specialist skills that you need at home. Also, when the tracheostomy tape is changed, again, this is an intensive care nursing skill. Imagine the tape is changed and the tracheostomy is coming out, and that's another thing. If the tracheostomy, God forbid, does come out, you need the intensive care nurse there to be able to manage this unstable situation and put the tracheostomy back in, within less than a minute, to avoid any further damages. Also, what is important when you are going home, with nurses, it's also important that you have the nurses liaise with the hospital or with any specialist doctors that you will have going forward. So that is really important as well. Now, I also give you some examples. I mentioned earlier about that patients have died in the community if they don't have intensive care nurses 24 hours a day. I'm aware of other clients at the moment that are bouncing back between hospital and the home because they don't have 24-hour intensive care nurses at home. So it is really a very dangerous situation of not having the intensive care nurse 24 hours a day. It is literally life-threatening. So I really hope that illustrates of what is the quote-unquote blueprint for hospital and ICU discharges for patients with a tracheostomy, adults and children, and also making sure they are not bouncing back into ICU all the time, which is what we see when people don't have the 24-hour intensive care nurse. They either unfortunately die, or unfortunately they bounce back into ICU all the time, which is not what you want. which is not what the ICU wants either. You know, none of it makes sense, you know, whether it's your life or whether it's the hospital, you know, that you shouldn't be at home predictably. I think that is really the bottom line for our service. We keep our clients at home predictably, right? It's that predictability that we bring to our clients, their families, but also we bring that predictability to hospitals so they know they can safely discharge the patients into the community without having to worry about, or are they coming back? Are they bouncing back all the time? You know. So also, to sum it up here one more time, a registered nurse that hasn't got any ICU experience won't be good enough to look after a tracheostomy client in the community, because simply they haven't worked in ICU. You know, in ICU you get taught all the ins and outs of a tracheostomy, you know, and if you don't know the ins and outs of a tracheostomy, you are putting yourself or your loved one into a life-threatening situation, right? It's as simple as that. Now, now let's open the floor here for some questions. If you have any questions to today's topic, please type them into the chat pad. And if you want to talk to me directly here, you can use the StreamYard link here. You can click on the link and join me here live on the show, or you can type your questions into the chat pad. You can ask anything about intensive care, and if you don't have any questions, I have so many questions that have come in during the week that I can answer now. I just need to get to them. So please type your questions into the chat pad. I can see there's quite a few people here. Or you wait for me to read out the questions and answer them there. So let me have a look for some questions that have come in. The first question is from Tammy, who says, "Hi Patrick, my fiance is on dialysis and on a ventilator, and he wishes to go home but needs help with at least the ventilator or the dialysis. I could do one but not both. Please get back to me when you can about any information you have on this. I have done patient dialysis at home with him prior to him having the ventilator and the tracheostomy, but I'm trying to see if he can go home dialysis, ventilator and tracheostomy. Like I said, I can train for one if needed, but I couldn't do both." Yeah, I could not agree more with you, Tammy, that you can't do all of it. Look, doing dialysis at home is definitely possible. You know, doing dialysis, ventilation and tracheostomy at home is definitely possible. And we can set it up successfully, you know, and it's the same. Once again, you know, I mentioned I've just spent half an hour talking about why you need an intensive care nurse at home if you have a tracheostomy, and you need that 24 hours a day. And once again, it's evidence-based at the mechanical home ventilation guidelines. And you know, we can, similar to what I talked about before, we can set up home care for you with dialysis, ventilator, tracheostomy, send intensive care nurses 24 hours a day. And once again, I don't know where you are, you have not shared your location, but, you know, once again, it cuts the cost of an intensive care bed by 50%. You can already see that your fiance needs to be at home and not in an ICU, right? You have already seen that the grass is greener on the other side. It just needs to be safe, and we can ensure that, you know, a transition home for your fiance will be safe and seamless, you know, similar to what I talked about before. Let's organize the funding, let's organize a team, you know, let's organize the equipment, you know, and we have done it successfully many, many times. So I hope that answers your question, Tammy. Please reach out to us here at intensivecareathome.com. Go to intensivecareathome.com, call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecarehome.com. Next question. From Napreed, who says, "Hi Patrick, my father is 66 years old. He's been in ICU for 14 days. 2 days ago, they did a tracheostomy because he couldn't breathe on his own. He's still on the ventilator after tracheostomy because he still can't breathe on his own. The doctor said they will train him step by step. And it's really important if his heart and brain can endure during this challenging time. He is having neurological problems. The brain is not giving signal to the respiratory system to breathe. The other organs are okay. Keeping his vital signs within normal limits. He opens his eyes. He sheds tears sometimes. He responds to stimuli, answers to commands given by the doctor, but when told to breathe, he tries but gets tired immediately because his muscles are too weak. He was diagnosed last year with Parkinson's disease, diabetes, and he has little brain damage because of some little brain strokes he had. The last 3 months, he was losing weight because he couldn't eat and had sleep disturbances during the night and slept a lot during the day. Is there hope for him? How much it can take for him to recover and wean off the ventilator? What can we do for him? Thank you in advance for your answer." From Nafpreet. Thank you so much, Nafpreet, for sharing your dad's situation. So here's what they should do to begin with. They should have a weaning plan for him, right? And that would include physical therapy, weaning down, ventilation, going from a controlled mode to pressure support to CPAP ventilation mode. Those are the things that should be done first, right? But it also includes mobilization, which means getting him out of bed. That's going to be really important, right? Because you're talking about his muscles are so weak. Well, his muscles will not strengthen by him lying in bed. His muscles will strengthen by him getting out of bed, sitting in a chair. That in and of itself will strengthen his upper body muscles, and that in and of itself, with the muscles gaining more strength, will help him to wean off the ventilator, right? Also, if he's had some minor strokes and he's got some neurological deficit, imagine you're lying in bed with neurological deficit and you're lying in bed for weeks on end. Now, do you think it'll help your brain if you're sitting up, if you're getting stimuli, getting physical therapy, sitting upright, looking around, which is something that's difficult to do when you're lying in bed? You're staring at the ceiling. Well, which of the two would you prefer, staring at the ceiling or sitting in a chair and looking around what's happening? It is common sense. Don't let the hospital convince you they can't mobilize your loved one. Really don't. Because that's what they're often trying to do. They're trying to convince you that they can't mobilize your loved one. It's nonsense. It is common sense that in order to wean a critically ill patient off the ventilator, there needs to be some physical stimulation, i.e. physical therapy, getting out of bed, sitting upright, breathing exercises, physiotherapy or physical therapy, right? So, and then they need to work with a weaning plan. A good ICU will work with a weaning plan. They will map out steps. Today we're doing this, tomorrow we're doing this. By the end of the week, we want to have him in a different ventilation mode. In 8 days, we want to have a spontaneous breathing trial. Those time periods can be shorter. It really depends on the circumstances. It could be a goal like, okay, today we want to wean down pressure support. Tomorrow we're going to wean down PEEP, or the other way around. We're going to wean down the breathing rate. And in 2 days, we want to have a spontaneous breathing trial on a T-piece, on a tracheostomy shield, tracheostomy mask, right? But there needs to be a plan, right? The goal for any critically ill patient in intensive care must be to be weaned off the ventilator, adults or children, doesn't matter. So, God forbid, if all of that fails, right, despite of all the best efforts from the hospital, if your dad can't wean off the ventilator, absolutely, the best option probably is intensive care at home, right? But he's not there yet. It's only been a couple of weeks. Please do not underestimate the power of physical therapy and mobilization. It makes all the difference, right? It makes all the difference. And just because he's not answering to commands, to all commands just as yet, I mean, there's something there. You know, the more awake he gets, hopefully he can work with a physical therapist, with a physio, with the nurses, with the doctors to wean off the ventilator. He probably needs to be a little bit more awake for that. But that will hopefully come over time, right? So I hope that answers your question. Let's move on to the next question. In the meantime, if you have any questions in regards to today's topic or any other questions when it comes to tracheostomy, ventilation, intensive care, or intensive care at home, type them into the chat pad or join me live on the show here. Click on the StreamYard link and you can talk to me directly here and I will answer your question here. So, next question from Aubrey. Aubrey says, "Hi Patrick, my son has just left ICU and he has been discharged to my care and is now living with me with a tracheostomy. I'm not sure whether I'd be fine, but 3 weeks in and I'm absolutely exhausted. Can intensive care at home help?" Absolutely, Aubrey. Oh my goodness, I'm so sorry to hear that. This is exactly what I was talking about earlier at the beginning of the presentation, that whenever patients go home with a tracheostomy, they need intensive care nurses 24 hours a day. You know, Aubrey, you are at risk of losing your son. A, you are exhausted. B, you know, that's my whole point today. My whole presentation was about why you need intensive care nurses 24 hours a day. And knowing that patients have died in the community, adults and children, with a tracheostomy because they didn't have 24-hour nursing care with intensive care nurses, your son is at risk of dying, right? That is an unfortunate reality, right? And I'm not making it up. So once again, I encourage you to reach out to intensivecarehome.com, call us on one of the numbers on the top of our website, or send an email to info@intensivecarehome.com. Okay, so that was Aubrey. Elisa asking a question here says, "I have a question about decannulation. How do I advocate for my mother's decannulation? She just came back from the hospital to a sniff because she had mucus plugs from lack of proper humidity." Well, you see, this is exactly, I will answer your question, Elisa, but this is exactly my point. If she's been to a sniff, right, they wouldn't know how to humidify. And that's exactly why she's bouncing back to hospital. In a sniff, you don't have intensive care nurses 24 hours a day. That is exactly my point, right? You're lucky your mom is still alive, but, you know, a sniff wouldn't have a clue what to do with a tracheostomy, which is exactly why your mom bounced back to a hospital, because they didn't humidify. You know, this is, anyone that hasn't worked in ICU wouldn't know how to humidify, why to humidify, how often, how frequently, what else to check. You know, this is exactly my point. Anyway, so Lisa, how do you advocate? So the first thing is you need to find out, is your mom ready for decannulation? If she had a mucus plug because of lack of proper humidity, okay, let's just say she would have had humidification. Would she be ready for decannulation? I don't know. I don't have the answer. So here is what needs to happen if the tracheostomy should be decannulated. The first thing that should happen is your mom swallowing? Okay. If she's swallowing, great. That's one box ticked. Number 2, is she coughing? Does she have a good strong cough? Number 3, how often does she need suctioning? Right? How frequently do the nurses need to suction? Number 4, what's the size of the tracheostomy? Right? You know, the smaller the size, the higher chances that the tracheostomy can be removed. Number 5, is she also needing oxygen while she's on the tracheostomy, right? If yes, how much oxygen, right? Number 6, is she obeying commands? Is she following instructions? Is your mother awake, right? Can she follow instructions around, can she cough? Can she bring up her secretions? Can she swallow, right? And then number 7, does she have a cuffed tracheostomy or an uncuffed tracheostomy? If she has a cuffed tracheostomy, is the cuff down? Now, I know sometimes there's confusion around a cuffed or an uncuffed tracheostomy, but I can clarify that confusion because I show you a tracheostomy here. Just give me 1 second. Here is a tracheostomy. Okay, this is a cuffed tracheostomy, and cuff is down right now. Okay, you can see the tracheostomy here, and the cuff is down right now. Now, I will show you how to inflate the cuff, and I will show you what the purpose of it is. Okay, so now this is the cuff. Oh, sorry, this is the tracheostomy, cuff is down. And now I put the cuff up. Can you see that? The balloon is going up. Okay, so what's the purpose of all of this? So when someone is having a cuff tracheostomy and the balloon is up all the time, right? And if someone can't swallow, that's okay. The balloon is up and prevents secretions from going into the lungs, prevents aspiration, okay? If you know that someone can't swallow, you leave the cuff up. For kids don't have cuff tracheostomies, but the tracheostomy, is sealing the airway anyway because kids have such a narrow airway. Okay, so if you want to find out if someone can swallow, you put down the cuff, right? You put down the cuff. And when you put down the cuff and someone can't swallow, right? Well, what do you do then? You put the cuff up again. But that's also a sign that she or your loved one is not ready to swallow, and therefore the tracheostomy needs to stay in until the swallow test has been passed. Okay, so Elisa, coming back to you. So she is swallowing, she's coughing infrequently, and she is awake. What was the answer to none? I can't remember now. What question did I? Never inflated. Okay, good. So that means she can swallow. She must be able to swallow. I would assume she has she passed the swallowing test. She must have done, right? So they suction infrequently. If they suction infrequently, what does that mean? Does that mean 2 times a day? Does it mean every 2 hours? What does that mean? Right? And maybe if you can type, because I am a bit confused by your answers here. The easiest way I can help you, Elisa, is if you come on the call here. That is the easiest way. Here's the link again. That's the easiest way we can sort out your problem. Never inflated. That's the quickest way I can help you if you talk to me directly here. You don't have to go on camera. You can just talk to me with your camera off. It's up to you. But that's the quickest way I can help you. Unless you want to type in detail, what your mother's situation is exactly. Okay, so in the meantime, I have another email here from Salvador, who says, "Hi Patrick, my dad is 60 years of age and has been in ICU for 8 days. He had motor neuron disease for the last 10 months. He developed sepsis and was hospitalized for the second time after 4 months. He has a G-tube, a PEG tube, but his large intestine was not getting enough oxygen and he had an internal ischemia. Part of his large intestine was removed. They did a colostomy procedure on him. He was in a medically induced coma for 4 days during these procedures. They did a CT scan of the abdomen to discover why there was not enough oxygen. Because of the motor neuron disease, he can't talk, walk, or swallow. His breathing and oxygen were not at the safest numbers, so he was intubated on a ventilator again yesterday. He's on 55 to 60% oxygen or FiO2. The GI doctor wants to strongly recommend taking him off life support. It's only been 8 days so far. He's on intubation with no sedation. Nurse says he's weak, but still tolerating the intubation with just pain medication, and he's drowsy and opens his eyes. Well, clearly, because your dad has MND, and let's just say he's got a will to live and a wish to live, he needs a tracheostomy. Here's what will most likely happen. Let's just take the best case scenario. Let's just say they can wean him off the ventilator and extubate him. He will need BiPAP or CPAP, at least for a few days. But eventually with the MND, he will need BiPAP or CPAP anyway. And if he needs BiPAP or CPAP down the line with MND and the inability to swallow, he is at high risk of aspiration and getting an aspiration pneumonia. If he ends up with an aspiration pneumonia, he will go into ICU and he will end up with another breathing tube, right? And then he won't be able to come off, and then he will need a tracheostomy. You need to consider whether a tracheostomy now is the right thing to do straight away while he's in ICU. Because the reality is, if he needs a tracheostomy down the line, he will end up back again in ICU. That is the unfortunate reality. Let me talk about motor neuron disease in general and what are the options. Most of you would have heard of Stephen Hawking, the renowned UK scientist who had motor neuron disease for most of his adult life. And he lived well into his 70s on a ventilator with a tracheostomy with 24-hour intensive care nurses. Right? That's just one aspect of life expectancy when it comes to motor neuron disease. Elisa, I'll let you in a second. Elisa, I'll let you in a second. Let me just finish here, and then I can let you in. So similar to some of our intensive care at home clients, they also live at home with a tracheostomy with MND for many years on end, right? So it's definitely possible, definitely possible. So a tracheostomy is the right thing to do here. But let me talk to Elisa.
Hello, Patrick. Are you there?
I am here. I can hear you. Can you hear me?
I can hear you. Yeah, there's so much what you're saying that at some point I want to be able to get on with you. Listen, I've stayed in the LTEX in the sniffs with my mother for 4 months. I have so much to tell you. And I can tell you that everything you say has guided me through this whole process. And it has been, for lack of better word, hell. But your advice has made it effective and made me, it's empowered me to make some decisions that have put me in a better position than the majority of the people who have experienced this, especially if they're not there, which is not typically the what happens. But I have, because of your advice, stayed and watched the whole process. And I tell you, even when you're there, there's so much unskilled or so many mistakes that if you're not watching, your loved one, and if you're not going to take them home, I just say that you're going to really have a really tough time keeping them alive. hmm So the idea is to get my mother home, and so she is in a sniff, and she has been we were trying to decanalate her, um, and don't know how to successfully do it because they're in the SNF and they don't even have an ENT who probably would be more of the correct professional to diagnose if she has swallowing issues and things like that. But at any rate, we're trying to get her decannulated. She had to go to the hospital yesterday from having, she has an infection. She had been suctioned a lot. Prior to this, she was coming from an LTEC where she did not have a lot of suctioning, but she had injuries from the LTEC. But she's at a SNF now, and she has at the SNF, they have no correct means to be able to hydrate her. So she's being hydrated on oxygen. She has not been on oxygen. So to make a long story short, um, she has not had any HMEs or access to an HME because they don't have them on hand. And I brought my own HMEs. I ran out. And since she has had no hydration, I had to advocate for the hydration. I had to tell them when to hook her up. And then not only that, it's not efficient for her. It's not the moisture that she needs because she has the mucus plugs. And so now she's just one day back from the hospital, which if you're at a SNF, they're not going to advocate for you to even go to a hospital. And then you have to, based on what you've told me, you have to take your power back. And so I had to essentially go against the advice, the recommended advice, get my mother to the hospital, which fortunately is across the street. And they had the mechanics to take out the mucus plug. They put back in a trach. Nobody told me that the trach gets colluded, the entire trach. They had to take it out, and this is after when she went to the IC to the emergency. They were going to send her back because they think they have the means here to unplug her. I says no, she couldn't even get her cannula back in, so they took the trach out. And when I saw how colluded that trach was, of course, the goal is to get all the services at the hospital where they have the highest quality of care. But I took a picture of the colluded trach, which when I was at the SNF, they told me, no, that doesn't happen. Of course it happens. Turns out you have to get the trach changed every month. It had never been changed from the time she left ICU at the to the LTEC, which she stayed in 2 months, and then to another ICU, back to the skilled nursing. It had never been changed. We've been here a month, so she's had the same trach for 4 months, and
I'm
it was
not
colluded.
I'm
Yes.
not surprised to hear all of that, Elisa, because once again, the minute you leave ICU, no one knows what to do with the trach. I'm
Yep.
not surprised to hear any of it. Just quickly talking about the HME, she
Yes.
should really only have the HME sparingly. She should have a humidifier attached,
Yeah.
right?
Right.
HME is fine. If people have community access, if they're going out, you need to use an HME.
Right.
However, if you are bed bound or chair bound, you should use not an HME, you should use a humidifier, much more effective.
Mm-hmm.
And the HME has probably contributed to the blockage,
Okay.
most likely, right?
Okay.
Right. HME is sort of a last resort. It's better than nothing,
Nothing.
but the gold standard is the humidifier. But they,
Yes.
like I said, no one would have very few SNFs, LTACs have an idea what to do
Yeah.
because they haven't really seen it.
Yeah.
Right.
Right.
Elisa, I do need to wrap this up here in a
Absolutely.
minute. I do apologize, but you're
No
welcome to
worries.
reach out to me outside.
Absolutely.
Just go to intensivecareathome.com or
Absolutely.
to intensive care hotline, and you can contact me through the website.
Absolutely.
But thank you for
Yes.
sharing with our
Absolutely.
audience.
Yes. Take care, Patrick, and thank you for all your
Same
help.
to you. Thank you
Yes.
so much. Thank
I'll
you.
talk to you soon. Bye-bye.
Thank you. Bye-bye. Bye. Okay, I do need to wrap this up in a minute here. I just want to obviously tell everyone that, you know, if you have a loved one in intensive care, you want to go home with a tracheostomy or on a ventilator, you know, please reach out to us at intensivecarehome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. Or you might be at home already and you might have insufficient support. You're bouncing back into hospital all the time, or going back into ICU all the time. You know, if you have a ventilator, if you have a trach, please reach out to us as well. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in regional and rural areas. We are an NDIS approved service provider all around Australia, TAC approved in Victoria, as well as WorkSafe, iCare in New South Wales, NIISQ in Queensland, as well as DVA, Department of Veteran Affairs, all around the country. We have also received funding through public hospitals, departments of health, private health funds, etc. We're also providing level 2 and level 3 NDIS support coordination if you need help with that. We're also providing NDIS specialist nursing assessments if you need help with that. And if you're an NDIS support coordinator and you don't know how to get nursing care funding for your participants, especially when it comes to ventilation, tracheostomy, home TPN, you know, IV potassium, IV magnesium infusions, IV antibiotics, port management, central line management, PICC line management, as well as Hickman's line management. We do all of that at home, and it's often NDIS funded, but also through other funding bodies. We also provide palliative care at home. We also send our critical care nurses into the home for emergency department bypass services. So if you need nasogastric tubes unblocked, nasogastric tube changes, PEG tube changes, catheter changes, catheter blockages solved, we can do that for you in your home or in a residential aged care facility, for example. We are also, hiring currently critical care nurses in Sydney, Melbourne, and Brisbane, and also in country Victoria, in Bendigo, as well as in Warragul, also in Albury, Wodonga on the New South Wales Victorian border. If you are a critical care nurse with a minimum of 2 years critical care nursing experience, and you have ideally completed a postgraduate qualification, we want to hear from you. I just want to be clear that we are looking for staff that can work on a regular basis with our clients. We're not an agency where our staff can come and go. That is not what we need. That is not what we stand for. We have a tailor-made solution for our clients, and that includes having regular staff work with them. Now, if you're an intensive care specialist and you're watching this, we're currently expanding our medical team as well. We want to hear from you. And if you are an intensive care specialist, or you are an ICU consultant and you have bed blocks in your ICU, which you definitely do have, we want to hear from you as well. We can improve the quality of life, and in some instances, quality of end of life for your patients and their families, adults and children, and you don't even pay for it, but we can help you free up your bed. If you're a hospital executive watching this, we also want to hear from you, because once again, we can help you eliminate bed blocks in ICU, pediatric ICU, as well as emergency department and on respiratory wards. Please reach out to us. Once again, website again is intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for intensive care at home, but also for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next or what questions and insights you have. And once again, thank you so much for watching, and thank you so much for your support. And if you need intensive care at home in the US or in the UK, please reach out to us as well. We can help you there privately. Have a wonderful and blessed day. Happy Easter, and take care for now.